Good afternoon, ladies and gentlemen. Okay, that's better. So we're going to have the next session, which is going to be a plenary and some presentations. And I welcome you back from the previous session. I hope the discussions were very fruitful, and I hope you learned a lot and shared a lot as well. So I'm going to invite the panelists to take their seats here as we dive into the conversation. My name is Nawanyaga Gloria. Once again, I welcome you back to this session. We are going to have a conversation on the role of religious leaders in the HIV response, including leveraging on the Vatican Rome Action Plan to end AIDS in children. Once again, my name is Nawanyaga Gloria. I'm a Global Alliance Community Champion to ending AIDS in children by 2030 and the coordinator of Champions. I'm also the founder of Gilo Young Posters Foundation, which is a youth-led charity organization that empowers, equips, and educates young people living and affected with HIV to improve on their livelihoods. Now, I believe that ending AIDS beyond 2030 has to start with children, prioritizing the needs of children and putting the needs of children at the front line. I don't know if you agree with me, but next generation, who agrees with me? Hello? Thank you, Sean. Yes, children are the next generation, and if we are to end AIDS and HIV, we have to start with children and prioritize their needs and make sure that they have a generation that is free from AIDS so that they can serve the next generation. So the discussion today is going to be around how we can end AIDS in children, but of course with an emphasis on religious leaders, because I believe even though we have religious leaders here or our panelists being affiliated to institutions, it's everyone's role to see that we protect our children from AIDS and then also being able to end HIV in children. So I'm going to invite the first speaker without wasting any further time. I believe we are time bad. She's going to be online, and that is he's going to be online, and that is Shafiq Radha Isaja and Dr. Nadita Sanjay, and they're going to be talking about sustainable HIV response with religious leaders advocacy, including through leveraging on Rome Action Plan to end pediatric HIV and AIDS. Are they ready? Media team, you can guide. Are they ready?
Thank you. Just give us a second.
Well, as we are still waiting for the media team and the speakers online, allow me to briefly introduce our panelists that you're seeing here today. They're very they're looking handsome and beautiful this afternoon. I hope you can also see that, right? Aren't they looking handsome and beautiful? Yeah. Let's clap for our panelists. Yes, so we have Elizabeth Oluchi. You can just wave, give them the bio when it's your turn. We have one and only Reverend Canon Gideon Biamugisha. With some round of applause, please. Let's clap for them. By the way, it's not easy to be up in front here. It takes some courage, you know, so we do really appreciate them. And Dr. Maggie, you're also very much welcome. So please just wave. Apologies, Shalik. Yes. Yes, I think we are already online. So I'm going to invite Dr. Shafiq and Dr. Nadita to take.
Can you let him know we can't hear him?
We can't. They're telling me that it's cut, so I think please inform them so that they can't. Yeah. Check.
We proceed.
Yes, we can now, but we can't hear you.
Check mic. Check mic. Check. Yes, we can hear you. Check mic. My microphone is off.
Recording in progress.
I think, can you hear us? Dr. Shafiq.
we hear you.
Oh, perfect. This is the time that I'm going to hand over to you to, yes.
Great.
So please feel free to take on the floor.
See the slides?
Yeah, sure, we can see the slides. Please go on.
Okay, fantastic. Colleagues, friends, it's delightful to be with you. You don't realize how important this is and what a privilege it is for us to be able to join you. And I wish we could be there in person, because the impetus and energy that you are creating is really so urgently needed now to help us all get through the crisis that we're facing. So over the next few minutes, my colleague Nandita and I are going to walk through a few quick slides to help frame where we are with pediatric HIV prevention and treatment, what the Rogue Action Plan has helped us in terms of galvanizing our collective response, and also a little bit of a way forwards, we hope, for some thinking that we can do to end.
Excuse me, doctor. Sorry to cut you short. I think we have different slides on the screen.
Go ahead.
Yes, can we have the right slides, please? The slides are for the next plenary, the next person, the next speaker. Can we have the right slides, please? Okay, perfect. We apologize for the glitches, technology. Sometimes it can misbehave. Otherwise, I hope we are fine. Are we fine?
Yeah.
Are you feeling hot? Not really? You're feeling cold? How are you feeling this afternoon? You good? You're feeling great? Awesome. I'm also feeling great. I'm actually over the moon. Yes. Perfect. So we have the right slides. Please, Doctor. Dr. Nandita and Dr. Shafiq, feel free to take on the floor. I hope you can hear us. Can you hear us? Dr. Nandita, can you hear us? Okay, Dr. Shafiq, can you hear us? Okay, please unmute us. Thank you. Dr. Nandita, can you hear us?
Better.
Okay, can you hear us?
Yes, we can. Can you hear us?
Yeah, we can, loud and clear.
All right, great.
All right, please go on.
Let's proceed without further ado, colleagues. I think this is not going to be new information for any of you. We have really made such important progress, and we're so tantalizingly close to achieving the goal of ending AIDS. I think you've all seen some of this recent data from UNAIDS, but an estimated 4 million new infections have been averted among children. Typically, in the pediatric HIV space, we don't see such high numbers, but this is something that we can truly be globally proud of. Many countries have been validated for having eliminated vertical transmission altogether, and a number of countries, even among the high-burden regions of sub-Saharan Africa, have actually been certified as being on the path to elimination. So tremendous progress has been made in preventing vertical transmission. And for children living with HIV, we now have the remarkable fixed-dose combination of pediatric ALD, which is really the first time that we've seen an optimal formulation that is child-friendly, readily available, and widely adopted and in use for first-line therapy in children. And we're seeing the impact of this in real-time monitoring where children have better suppressed viral loads. But at the same time, there has been a historic problem with pediatric coverage. We know that today, 57% of children living with HIV are on treatment, but that is 20 percentage points lower than in the adult population. And when you look across the cascade, from kids knowing their status, to those receiving ART, to those who are virally suppressed, you can really see how much worse off children are compared to adults. Children account for less than 4% of all people living with HIV, but 13% of HIV-related mortality. So we know that there's a problem with this. We have been working hard to try to fix this. And there's an example there that we've shown you of a technical brief on pediatric HIV case finding. This is something that is being taken up by a lot of countries now, and in particular in the countries of the Global Alliance, we've seen some real progress in implementing community case finding efforts to really try to close that pediatric treatment gap. So we're really getting close. And if we were to summarize where we are against all the targets for both adult as well as pediatric HIV, yes, we haven't reached the levels of viral suppression that we had hoped to achieve, but with the new formulation of pediatric ALD, I think that number is going to get a lot better. And for pregnant women receiving treatment, we are at 84% coverage right now. We should be at 100% coverage, so we still have some ways to go. And of course, there's a number of structural inequalities that continue to exacerbate our ability to access treatment. I'm going to hand over to my colleague Nandita to take over here and walk us through some of these ongoing challenges that I think we need to reflect on in our discussions today.
Thanks so much, Shafiq, and greetings, everyone. Again, I apologize for not being with you in person, but thank you so much to the organizers for inviting us to join you today. And as Shafiq mentioned, he's speaking about a lot of the advances that we have made in access to medicines in the HIV movement. It really has been remarkable. We can't forget that. But what really is the barrier are these structural inequalities. And we have multiple global crises right now. So things that contribute to the ongoing HIV epidemic is gender inequalities that continue to persist. And we know that adolescent girls and young women are the most affected. And we can see, when we see IPV, we know that it increases the risk of vertical transmission. So there's a correlation there. And if you see, when we now look at maps visualizing our data, we see that there are multiple crises that are overlapping on top of each other and increasing risk of HIV. We also know that adolescents and young adults also have struggled to access sexual and reproductive health services. This includes age of consent, but it also includes the healthcare workers, how the system or how we are providing services to them. And really we have to remember that these are young people that have the right to make decisions about their own sexual and reproductive health. And then lastly, I want to point out there's still ongoing criminalization and stigma against key populations. And as much as we don't think about key populations being a pediatric issue, we do have to recognize that all adults can be parents, and many of them are. And so if we are also thinking about services for key population groups that otherwise are marginalized and need services, we have to remember that the parents also require services for their children. So we want to make sure that when we are advocating for equitable access to ARVs, that we make sure that we are reaching all children of all populations. Next slide, please. So what is at stake today that has brought us all together? I think there's been a lot of, again, multiple crises in the world, but one of the biggest, factors here is the sudden removal or the sudden ending of USG funding. And just yesterday, there was a really fantastic piece published by The Lancet by our very good friend Lucy Kluver, Dr. Lucy Kluver, that looked at what's the impact of losing the services that we've put together with this funding. And so some of the models that have been put together, that without the continuing investments or without more attention to this, we will have an additional 1 million children infected with HIV by 2030. So we're even going beyond what we have now and more than doubling the number of children. We also see that 500,000 will die of AIDS, and many of us here in this room have seen this happen. It is not something we will ever want to see again, and to see 500,000 at risk is something that we should be shouting about. And lastly, 2.8 million children will be orphaned by AIDS. And so these children are the most marginalized. And again, we see that not only have health services been stopped, but also support for their educational and nutritional needs through OVC programming. So I just want to point out, this is really what's at stake when we think about coming together as a global community to end pediatric AIDS. Next slide, please. So I want to talk about the Rome Action Plan. I don't know how many of you have been involved with this. There were many organizations and leaders in the field who worked on this platform. So this started in 2016. And it was actually started when there was an organization who raised their voice about the fact that they were having pediatric ARV stockouts at their facilities. And this is what built momentum. So I want to point out, it was one organization, one person who raised their voice. And I'm going to raise it now because there's an airplane flying over me. But raising your voice can work. And so from there, it grew into higher level dialogues that were convened, really focusing on the acceleration and scale up of infant testing and the introduction of optimal regimens for children. And they continued, and you can see through the years, when you think about what happened, 2016, 2017, 2018, we had a lot of other crises going on. We had COVID in particular, which really changed everything. So now here we are in 2025, And you know, for the last 4 years, this has become a virtual community that's maintaining this dialogue and sharing updates regularly so that we have been keeping on track. So even in a time of crisis, we have all been able to stay together to make sure that we still have access to medicines and diagnostics for children. Next slide, please. So I want to speak about what happened very recently. So at the beginning of February, some of you were participating in this event, but the Rome platform and the Vatican brought a dialogue together. So there were over 70 key leaders and representatives across the board. So it was really a very mixed group. We had the private sector there with diagnostic and pharmaceutical companies who are committing to continuing making the products that are needed. Researchers were there sharing their clinical research and what they are working on next. Funders were there to recommit their funding priorities for children's needs. There were faith-based organizations, civil society organizations, multilateral organizations, government and regulatory agencies. And all of these groups recommitted their organizations to continue serving children affected by HIV. We all, as a very diverse group, recognize the potential as well for learning from what we did in HIV. Can this work in other diseases that affect children? And in the end, what was created was a new global health leadership, or a vision for a new global health leadership that is built on a sustainable and stable platform. And I would think that the HIV movement, we all stand together. I think that's something that really we have to remember at this time. Next slide, please. So out of this dialogue came 9 new recommendations. And really the take-home message here is that a fundamental shift is needed in how success is measured. So just earlier this morning, we were looking at the data that Jeff Eaton was sharing with us about the numbers of these populations that are affected by HIV and that are really at risk. And the numbers themselves mean a lot, and it's worrisome, but it takes away from thinking about, at an individual level, what's really happening to that child. So we really need to think about how success is measured. We need to adopt a bold new narrative for pediatric health that includes HIV and TB. We need to forge new and inclusive partnerships and reform structures, and we saw a great example of that with the Vatican Leadership Dialogue, with many different partners and new partners coming together. We need to integrate models and approaches. So this is models and approaches for primary health care, but models and approaches of things that work for HIV care as well. We need to harmonize regulatory frameworks so that there's more cooperation, continue investing in innovation, leverage digital tools and artificial intelligence. Now, this is something we did not have 40 years ago, so we really have made progress. But we need to also reprioritize financing and strengthen national ownership, and that is the dialogue that's happening today. We are strengthening advocacy, harnessing the influence of faith and community leaders and networks. And again, this is part of a strong, stable community that continues to come together. And then let's think about what global health leadership looks like. This is not, so I think this is an opportunity, and this is something that's starting now. So I want to be hopeful that these recommendations will help us make this fundamental shift. Next slide. Shafiq, do you want to go on to some take-home messages?
Sure. Colleagues, we really want to give you some time to discuss this in the panel discussions. But in closing, we wanted to share some take-home messages that I think are important for us to reflect on. Nandita just walked us through some of the highlights coming out of the 7th Rome Leadership Dialogue. But I think it's important for us to reflect that those recommendations do not encompass all the things that we can do together as faith-based organizations and communities coming together to work on how we address some of the challenges before us. They give us a start, but they don't encompass all of the things that we could be doing, especially around service delivery. So we all have a role to play, and Rome 7 has shown us that there is a strong commitment from industry, but I think it leaves us, those of us who work closer to the ground on actual delivering care, to think about three things that we need to focus on urgently. The first is government rights of children, including the rights of children to health. And it's time that we made that case strongly for government to take on that task and that responsibility. And religious institutions, religious leaders have a critical role to play in this, because they are listened to by governments in ways that sometimes activists cannot get the same degree of leverage. So we need to come together to focus on how we can do this. I think it's clear that service delivery going forwards is going to need and draw on the strengths of communities. This is something that we've talked about for a long time, and it's becoming even more urgent now that we see that some of the facilities, structures, and systems that we had put into place are so easy to unplug and to ultimately fall apart. And so recognizing that we have to have strength and investment and support from the community to deliver on services is, I think, going to be a game changer for us going forward. We have to do that smartly. We can't dump the business of service delivery entirely on communities, but rather recognize their strength and the value that people living with HIV, that networks have in trying to support and sustain services for their own communities. And I think the third piece, and this is especially important for children, is the role of integration. Now, there's a challenge with integration, right? We want smart integration. We don't want integration that relegates marginalized communities and populations to the invisible categories that they were in before we set up some of these structures and systems to treat communities and people living with HIV. So rather than integrating into health, the question we need to be asking is, how can we help primary healthcare systems become truly responsive to communities affected by HIV? For children, for mothers, and for all people living with HIV, primary healthcare needs to be able to respond to those populations in different ways to the way in which primary healthcare has been structured. And I think we can bring from our HIV experience some of those principles of consent, of confidentiality, of caring and compassion into the primary healthcare space to help that primary healthcare program around services for children. I'm going to turn over to Nandita for the remaining.
And I will say, and thank you, Shafiq, because you've really pointed out that we have learned a lot over the last 40 years, right? So there is a lot more we have, and no one can take that away once we learn what to do. So we've learned from the HIV movement that community activism is effective, that advocacy is important, I will say critical. And human rights is also at the center of what we do, not just in HIV care, but as Shafiq mentioned, across the health sector. Now, protecting the health and the rights of children, it's not a service. We're talking about models of care and so forth. But again, these are children. And it's on us, it's a moral imperative for us to make sure they remain safe and taken care of. And that is the only way we will have a future. And I'll also share that the Global Alliance has formed, and this is an alliance that has come together from 12 countries and supported by their leadership from sub-Saharan Africa. So this is a group that meets regularly, that shares lessons, that builds on collective efforts of past initiatives. So we all are now one community, but we continue to learn together, and we continue to track progress together. So I think we have a lot of tools and a lot of, I think we just have a lot at our disposal. We have a lot that we can do, and we can't forget about those things, and we can't let go of these things if we really want an AIDS-free generation. Thank you.
Wow. Thank you so much, Dr. Nandita and Dr. Shafiq. I think they deserve a round of applause. I hope you can hear those hand claps. Those are for you. That was a very wonderful presentation. And I don't know if you have questions. Do we have questions? No? Perfect. I believe the presentation was also perfect. So Dr. Nandita and Dr. Shafiq, thank you so much for joining us. I hope you will keep on keep online so that you can listen into the whole session. So without wasting any time, I'm going to invite Margaret Mungwa to come and take us through integrated HIV services for children, adolescents, and young women, experience of Pata Youth Care Project in Kenya. Let's give her a hand clap. I hope you can keep it as brief as possible because you're really out of time.
I'm going to keep it short because I think since yesterday I've been talking over and over again about the same thing, and we've talked about integration. I think we had two groups, Group 1 and Group 3 in the afternoon. And I think we are there. We are trying to get solutions on what we can do. I won't go into the presentation so much. I don't know if you are able to project the presentation. Because we feel integration, just like Flo in Group 3, she was saying, it's like a tuk-tuk. Do you know tuk-tuk? How many of you know tuk-tuk? The small, it's like a motorcycle, but a bigger version. And we are trying to fit a Prado into a tuk-tuk. So you can imagine. And Sibo told me integration is like a lady who is still staying in their parents' house and has a rich boyfriend and has been shopping, paying Wi-Fi, paying the nanny, and now the rich boyfriend is gone. So, so you can imagine how is she going to sustain the house, the Wi-Fi? Do you get the good trained nanny who was there? How are you going to change that nanny to another nanny who is a bit affordable? So I'll start my presentation, and I think we've had this conversation several times, so I'll not take much of your time. I'm going to give reflections from the health provider, from the grassroots, that is at health facility level. I know it looks basic, isn't it? Because it's at the ground level. But some of the things that happen at the ground level is what shapes the national priorities. So I'm going to give a reflection, and this is not something we've done, an assessment. It's just feedback while we were doing the scorecard, the community-led monitoring, and we were giving feedback from the scorecard to the health providers, and some of these insights are from those discussions. Next slide, please. Next. So I'm going to give insights into what has happened so far from the US program termination, the different models of integrations that are currently happening. Remember, this is such an abrupt process to the health facilities, and it began with a memo from the national government asking the facilities to integrate. So much of the time, it's like a bit of a mess at the ground because they are trying to, trying different models and seeing what's working and what's not working. Then I'm going to look at service delivery and EMR challenges. Those are there, and we've had there's downtime on the EMR, there's downtime on the KHIS. So what is our data dashboard at county level, national level? How does it look like? Then I will talk about some of the transitioning, what is happening to the HIV clinics, especially in big facilities that are level 4 and above, how they are transitioning to chronic conditions management clinics, and I'm going to look at opportunities and next steps. What is it that we can do? But in the opportunities, I think I'll touch on what we've discussed and see some of those things that were coming out. Next slide. So this process was from the scorecard, and I've talked about it. The scorecard results is what triggered the conversations around the impact of the US termination, the integration models. So this presentation is just a highlight of perspectives, and I think moving forward we need to do an audit of what's working in terms of integration at facility level, so that we can be able to address those challenges as we start the integration process, as it's ongoing in early stages and not waiting when it's too far gone. Next slide. So what is happening right now in the HIV clinics is that 80% to 95% of all healthcare workers who are working in that space were partner supported. So likelihood in the next few months we'll have those staffs facing attrition. That means that the cream de la cream of health providers who are providing HIV care services are likely to go home. So what happens next? Now that we are left with clinicians who are operating at the OPD, who are not extensively trained and exposed to HIV care work. The next thing is that I could notice from the sessions there was a lot of emotional distress. Because we do these sessions together with one person from the CHMT, who is always the CASCO, the County AIDS and STI Coordinator, accompanies PATA during the scorecard feedback sessions. There was a lot of asking what next is it for them? What would happen to them in the next few months? And you'd notice there was a lot of frustration, anxiety. What I've noticed today is that anxiety is also with the clients, because they are also unsure of what is happening next. Then staff morale is also reduced, and then there is increased burnout. There was a session where there was the stop work order, and health providers were asked to go home. So there was an opportunity where there was overload, workload piled on the OPD. They were given different types of reporting tools. There was the EMR system, there was the TB tablets, and they could not know how to go about that. So there was also increased burnout and lower motivation, and then they have concerns about continuity of care and also sustainability. Next slide. So what, I'll just give a snapshot. We have integration, HIV integration at theoretical model. All of us know about it, it's the blueprint. But what is happening in practice at facility level is something we need to also learn about. So there is staff rotation again as a way of integrating. Staff are rotating across various clinics, the HIV clinic, the MCH, and the OPD. This, we feel, is also a good model because it promotes skills building around health providers, so that they are more well-rounded compared to them actually just sticking to one service area. So we also noticed that there is also improved case detection, there is linkage to care. But what we notice also, there is increased workflow disruption. There is a bit of staff resistance, especially those who are not working in the HIV clinic or HIV care work. There is increased workload. Next slide. Oh my God. Next slide. There are a lot of positives. I'm not going to dwell into that. But what I feel is that there is unstructured transition in terms of the rotation. There is also, we don't have SOPs for the rotation. So I understand that currently we have the Integration Technical Working Group, especially for Kenya. But who is there? Who is sitting on the Technical Working Group for integration? Because so far we don't have any policies that are available on integration. And how can we feed into those integration policies and plans that they are coming up with? Next slide. Then there is, I've talked about integration at OPD, so you have everyone go through the OPD within the system, so that means they've done away with the CCC clinics. So CCC clinics are now consultation room 1, consultation room 2 and 3, so there's no longer HIV clinic, and everyone goes through the OPD. So what we noticed with that is that there's disruption in the workflow, there's also staff resistance, and then there is, because of the new patient flow, there is also increased waiting time, and also the fast tracking of HIV clinic approach is also lost there because there is no longer support and follow-up or adherence support for our clients. Next. So I've talked about EMR challenges. There've been a downtime with the EMR system. So far, when there was that downtime at the county dashboards, what you could see is like missed appointments, like 70% missed appointments, which was worrying. But when you go to the facility level, this is not the case. That means a lot of clinicians who are not exposed to the EMR system are not able to use the EMR systems. And also I noticed that also the KHIS system is also down. So how do we harmonize all these systems? And then how do we train health providers to use these systems? Next slide. Then I talked about large facilities which are level 4 and above. Some of them have been, the CCC clinic or the HIV clinics have been transformed to chronic conditions management. So only those with high viral load will be seen at that point and other chronic conditions. Next slide. So I feel there's a lot of training gaps, and also there are so many opportunities that we can tap in and to ensure inclusivity. So I want to look at integration is not, for HIV is not normal. It's not like a normal disease. So there's a way that we can actually join into the conversation as they work on integration policies. We want to look at peer-led models. How are they going to be integrated? Community outreaches or community-led activities, how are they going to be integrated? How are we going to ensure that scorecard are part of the integration or community-led monitoring? And also we need to have conversation about social health insurance fund. In terms of HIV is not included in that, how can we make sure that it's integrated as we move towards universal health coverage? Then there's what is the formula for integration? What is the process for integration? Where are the gaps? What's working? What's not working? I think we need to put our voice into that process. Thank you.
Thank you so much, Margaret. A bigger round of applause. And thank you for keeping it short. And indeed, integration is like a rich but not rich girlfriend who has a rich boyfriend. Now the rich boyfriend has taken his money. What is next? Sorry, get another boyfriend. I'm kidding, I'm kidding. Anyways, so we are going into the panel session, and I really hope we can have your attention at 100%, the maximum, but I feel the room is very dull. Maxi, I see your head is like, oh my God, when are we finishing? I'm kidding, we are soon finishing, I'm kidding. We are soon finishing, and we're going to, yes, we are going to finish, and I'm going to request the technical team on the sound to help us with the second microphone so that we can dive into the panel session. Okay, so do we have a second microphone?
Here.
Okay.
Young person to the
Okay, we'll start with the young person. No, the young person to be. Is it young person to be? Young person to be. No, let's start with you, Reverend. Just briefly introduce yourself in 1 minute, then we go into the first round of the questions.
Gideon Baguma Byamunisha means blessing. And as I said, I started the movement of religious leaders living with or personally affected by HIV, together with my 8 other friends.